Coming to your pulmonary complications, they are hepatopulmonary syndrome, portopulmonary hypertension, hepatic hydrothorax, or atelectasis and some infections. And the patient with liver disease might have some comorbs related to respiratory system, including COPD, OSA, and pulmonary thromboembolism. Firstly, hepatopulmonary syndrome. The name itself is saying something related to liver is affecting your pulmonary system. Okay? If we hear the word hepatopulmonary syndrome, we have to remember a diagnostic triad. The diagnostic triad means three things. In that, it should include the liver component and also your pulmonary component, right? So, there has to be liver dysfunction and pulmonary components including unexplained hypoxemia. The hypoxemia should be unexplained. The pulmonary causes we won't consider here in the diagnostic triad, right? The third thing is there should be intrapulmonary vascular dilatations. How to diagnose each of them is unexplained hypoxemia. That means there is some oxygenation defect. There is hypoxemia. How much hypoxemia are we talking here? The PaO2 has to be less than 80 mmHg and the gradient, alveolar arterial gradient has to be greater than or equal to 15 mmHg. Okay. Second, the pulmonary vascular dilatations, how we will know is we have to do contrast enhanced echo or radioactive lung perfusion scanning. Okay. The third thing is liver disease. There has to be liver disease, portal hypertension with or without cirrhosis. So these three is considered as the diagnostic triad for hepatopulmonary syndrome. What are the clinical features? The patient will have cyanosis, clubbing, cutaneous telangiectasias, orthodeoxia, platypnea, and dyspnea. Okay, let us see what is orthodeoxia and all later. So, these pulmonary vascular dilatations are two types, type 1 and type 2. The type 1 is the most common and it is precapillary dilatations at the alveolar level, whereas type 2 are relatively larger dilatations and are centrally located. Type 1 are your functional shunts and type 2 are your anatomic shunts. Generally, functional shunts will be treated with, if we increase the FiO2, the functional shunts might get better and the oxygen levels will be increased, but this won't happen with anatomic shunts. So, what happens if there is intrapulmonary vascular dilatation? See, this alveoli, this is your alveoli, this is your vessel. Normally, what happens? There will be blood flow through the vessel and the oxygen gets diffused into the alveolus. In cirrhosis, what happens is there will be hyperdynamic circulation that we will learn later in your cardiac manifestations. Okay, please remember there will be hyperdynamic circulation first thing. And next there is pulmonary vascular dilatation. These two things affect the transport of oxygen from the vessel to the alveolus. How? See, there is this is your alveoli. This is your blood flow. If the blood is flowing fast, what happens? There won't be any time for the oxygen to diffuse from this vessel to your alveolus. And added to this, there is vascular dilatation. So, for the oxygen to transfer from here to the alveolus, it will take time. And there is no such time because of hyperdynamic circulation. So, there is resultant hypoxemia. And this is your functional shunt and it can be corrected by increase in FiO2. If that is not getting corrected, that means it is of type 2, which is anatomical shunt. And what happens is there will be positional oxygenation here. That is your orthodeoxia. This vascular dilatations are more at the basis of lungs. So in supine position, oxygenation is better as blood distributes from basis to apex. In supine, blood diffuses from basis to apex and the vascular dilatations are more at the basis. So oxygenation is better in supine position, whereas standing the hypoxemia worsens. So how they will grade this? We will, in the diagnostic triad, will be grading based on the oxygenation defect, that is PaO2 and alveolar arterial gradient. We can't grade the pulmonary manifestations based on the liver cirrhosis, right? So we will be taking the pulmonary component in the diagnostic triad. So mild, moderate, severe and very severe, in all the gradient is greater than or equal to 15. We will be dividing based on the PaO2 levels. Greater than 80, it's mild. 60 to 80, moderate. 50 to 60 is severe. Less than 50 is very severe. So, why this happens? The pathogenesis might be due to your nitric oxide or endotoxemia or decrease in clearance of inflammatory mediators or angiogenesis or genetic factors. All these may contribute to your pulmonary vascular dilatations and hypoxemia. So, diagnosis we have already seen either the contrast enhanced echo or technician labeled macroaggregated albumin. So normally, if there are no pulmonary vascular dilatations, what happens is this albumin are trapped by pulmonary capillary blood in less than 2 cardiac cycles. But if there is delayed appearance of this micro bubbles in your left atrium, that means it is taking more time, more than 3 to 6 cardiac cycles or greater than 5% extra pulmonary uptake. That means brain uptake and all. That means there is presence of IPVs, your pulmonary vascular dilatations. So the treatment is mainly liver transplantation. Post-transplantation, the correction is generally universal. But if in the severity grading, if the PaO2 is less than 50 and the technetium macroaggregated albumin test quantified shunt fraction is 20%, that means there is more chances for mortality regardless of transplantation. So this is your hepatopulmonary syndrome. So we will be remembering the diagnostic triad and how they will diagnose the IPVDs and what are the types of IPVDs and how this vascular dilatation are affecting or causing the hypoxemia and symptoms mainly orthodeoxia, and also we have learned the treatment, that is your liver transplant surgery. Second one is portopulmonary hypertension, that is hepatopulmonary syndrome. This is portopulmonary hypertension. The name here we have to remember is hypertension. So we'll be talking more about pressures here. It has to have again the liver component and pulmonary component, but we will be talking about pressures. Let's see. Diagnostic criteria include evidence of portal hypertension has to be there. That is your liver component. Pulmonary component includes your mean pulmonary arterial pressure has to be 25 mmHg at rest or 30 mmHg during exercise. So, here diagnostic criteria includes all the pressures. Firstly, your mean pulmonary arterial pressure 25 and 30. Okay. Next, mean pulmonary arterial occlusion pressure. It has to be less than 15 mmHg. And third thing is pulmonary vascular resistance has to be greater than 240 dynes per second per centimeter square. Please remember these values 25, 30, 15 and 240. This occlusion pressure might be replaced with transpulmonary gradient, that is difference between mean pulmonary arterial pressure and the occlusion pressure, and that has to be greater than 12. Okay, in this diagnostic criteria, this is not it right. We have four things. The pulmonary component is your portal hypertension. The hepatic component is your portal hypertension. The pulmonary component are your three, your pressures and also your vascular resistance. Severity is based on your MPAC. There, it is based on your PaO2 levels. Here, it is your mean pulmonary arterial pressure. Mild, moderate, severe. There, it is mild, moderate, severe, and very severe. Here, it is mild, moderate, severe. Less than 35, 35 to 40, and greater than 50. Less than 35, 35 to 50, and greater than 50. So, pathophysiology, there we have learned about your endotoxemia or NO or genetic factors, etc. Here, and also the IPVDs, how they cause hypoxemia. Here it is. First, there is chronic liver disease. There is portal resistance, increased portal resistance, right? Apart from that, there will be pulmonary vascular remodeling. That means there will be intimal proliferation. The lumen is getting decreased. That means there is vasoconstriction. So there will be obstruction to the flow and finally resistance to the blood flow causing hypertension, causing more pressures, right? What should happen to for the pressures to increase? There should be the lumen should be decreased. The lumen is getting decreased by intimal proliferation. There will be vasoconstriction, vascular remodeling. All these are causing you pulmonary hypertension. Secondly, there is increased cardiac output because I have said in the cardiac manifestations, we'll learn it later. There will be hyperdynamic circulation and increased cardiac output in cirrhosis. So this increased cardiac output causes shear stress and again it in turn causes vascular proliferation. So the main thing is vascular proliferation caused by either directly portal hypertension or your increased cardiac output. And both these causes pulmonary hypertension. Other causes may be hormonal, immunological or endothelial proliferation. So finally, what are the on a wholesome manner? What are the clinical features of your portopulmonary hypertension? Are see first there is in the lungs there is increased vascular resistance. So there is vasoconstriction. Your mean pulmonary arterial pressures got increased. So this causes load on your heart. So there will be what happens right ventricular overload and right heart failure. This causes again your hepatic congestion. So please remember in a stepwise manner so that you don't just by heart, just remember the sequences, what might happen. There is vasoconstriction, already liver is affected. There is vasoconstriction the pulmonary arteries, increased empaths. This causes right ventricular overload, right heart failure, hepatic congestion might happen. So these are on a whole your pulmonary and also symptoms regarding heart and liver in portopulmonary hypertension. So symptoms dyspnea, weakness, decreased exercise tolerance, and diagnosis is by transthoracic echo. Will be seeing the RVSP and your right-sided cardiac catheterization helps to confirm it. We'll be knowing about your the resistance, pulmonary vascular resistance. So coming to treatment, what we have to do is there is vasoconstriction, so we have to aim for vasodilatation, right? So specific vasodilator therapy will be giving or diuretics and endothelial antagonists like bosentan. But please remember, bosentan might have liver toxicity, but it is not that significant clinically. We can give epoprostenol. It decreases pulmonary pressures, but it has antiplatelet effect and also increases vascular remodeling. In liver cirrhosis, there is obviously decreased platelets. Again, if we give epoprostenol, that might have effect on platelets, right? So it limits its use generally. But if we want to use, it has to be used in a continuous infusion and the interruptions has to be decreased. Coming to PD inhibitors, sildenafil, this cannot be used for a long-term thing. So it acts just like a window before the liver transplantation has been done. Please remember, normally in the pulmonary hypertension, we can give calcium channel blockers. But in portopulmonary hypertension, we should avoid calcium channel blockers because it might worsen your portal hypertension. Lastly, liver transplantation. It is tolerated if your MPAPS is less than 35 mmHg and it is contraindicated if it is greater than 50 mmHg. Okay. Lastly, hepatic hydrothorax. It is nothing but hepatic hydrothorax. That means there is transmigration of fluid from abdominal compartment to your above the diaphragm. That means into your respiratory part compartment. How does it occur? There is obviously openings in your diaphragm, small openings. The intra-abdominal pressure is increased due to ascites, whereas in the thoracic compartment there is negative intrathoracic pressure. So due to this positive and negative pressures and more ascitic fluid, this gets transmitted from abdominal compartment to your thoracic compartment. This hepatic hydrothorax is more towards right side and the type of fluid is transudative fluid. So, firstly, we have to rule out other causes, might be respiratory or serious, and then we'll be diagnosing that it is because of your hepatic thing. Obviously, clinical features will be your SOB, respiratory failure and cough, and how we will manage is there is fluid. So, we have to remove that fluid. We'll be doing thoracocentesis and we'll see the cell count in that fluid, and if there is infection, we'll be treating it with antibiotics. We have to limit the salt restriction. We have to limit the salt intake. And if it is recurrent and resistant, we'll be going for fluorodesis or TIPS. So, what your anesthetic implications in a liver patient concerning your respiratory system are? There is increased size of liver. There is more ascites. The diaphragm is being pushed towards upper side. So there will be decreased FRC, there will be atelectasis. So there has to be adequate pre-oxygenation because these patients are more prone for desaturation rapidly during your intubation time. And also intra desaturation might also have, there are chance for intra desaturation also. And post-op oxygen requirement or ICU requirement might also be there. So these are your anesthetic implications regarding respiratory system in a liver disease patient.